and welcome to Skincare Confidential, a podcast supporting the Science of Skincare Summit, an educational conference occurring in Austin, Texas on November 8th through 10th in 2024. Today, I am so excited. My name is Dr. Ted Lane. I am the host of the podcast today, along with my co-host, Dr. Patty Ferris, who couldn't be with us today, but I am excited, as you can tell, to introduce my guest today, Dr. Cara McDonald. So we are kicking off our international dermatology series. So I'm going to start interviewing dermatologists from around the world. And we're just learning about their life and what it's like to practice in a different country, but also about what's important in terms of skincare in that country and in that region, and how they integrate skincare into their both medical and aesthetic practice. But Cara, thank you so much for joining us today.
My absolute pleasure. Thank you for inviting me to join you.
And as you can tell, Cara is from Australia. Where are you in Australia?
I'm in Melbourne, so pretty big city, but my practice is actually just on the outskirts of Melbourne. So we also see a big rural population, actually.
Okay, great. And so, Cara, tell us about kind of your training, how you became a dermatologist, why you became a dermatologist, especially in Australia where dermatology is so important.
Yeah, well, it's always kind of a bit of a long story, isn't it? But I've loved working with people, and when I was at school, I thought about being a painter or an artist as my profession, and I decided I'd be very bored because I wouldn't be with people. But as soon as I started doing medical school and got exposure to dermatology, I loved the visual aspect of dermatology, and I think it really ties back to that artistic and visual component of me that I have, a creative component. And I loved that I could see different things in dermatology. I loved that I could see different rashes, different spots, different dots, and a lot of the diagnosis is visual. And that really appealed to me. I think that was the first thing. But then I also realized that I'm very task oriented. I like to be able to see something and preferably do something about it. And I think there's no specialty like dermatology where you can combine medicine, looking after people, and actually being able to help not only their skin, but help them in their lives as well. So I think that appeals to me. And really the reasons just kept adding up for me what appealed to me about dermatology. And I still absolutely love it. I love it as a specialty. I love helping people. I love seeing the difference in their skin and then in their self-esteem and confidence when you can help them. I love the fact that we get to see people from, literally birth through to death. And, I probably shouldn't say this, but I do love the fact that most of our patients aren't actually sick. We help them, they've got something wrong with them, but we're not actually dealing with people who are very unwell, which, being a kind of upbeat person, I always find that quite pleasing.
And so you have primarily a outpatient practice, right? So you're therefore not in the hospital very much seeing patients?
Yeah, look, I actually do have a hospital position as well, but certainly in Australia, we have very few inpatients in dermatology these days. We do still have ward beds. My role in the hospital system, training the residents, is mostly in the surgical side. It has varied over the years, but at the moment, my teaching is all surgical. So I'm not dealing with the medical inpatients very much. And the majority of my work is in private practice. Which is a mixture of aesthetic, laser, surgical, and some medical dermatology. I do less medical now than I used to, but I still do a mix of everything.
And by surgery, you're doing Mohs surgery?
No, so just basic surgery. We do have a Mohs surgeon in our practice, and so we have a huge tumour load in Australia. And most of our patients don't have Mohs surgery. That's probably one of the bigger differences in Australia, I think, compared to the US. But I would say, 90% of the patients don't have Mohs surgery for their skin cancer surgeries. We only use Mohs surgery probably just because of the availability and cost. If it's a, poorly defined tumour or a difficult site, I see quite a big load of skin cancer patients, and almost all of them have, you know, surgical excisions done in the private practice without Mohs.
How about that? So are you doing flaps and grafts and the whole
Yep.
bit?
Yep.
Okay.
So
And that's
we'd get a fair bit of that training in our
okay.
training program in our residency.
Okay.
So yep, I do pretty much anything you can do under local anesthetic, big flaps,
Okay.
grafts. But when it's appropriate to do that, as I said, we do still use Mohs, but the access to it is more limited. So maybe it's slightly wider margins, but
Yeah.
most of these um, you know older sun damaged people are very happy to go ahead with that kind of surgery.
Yeah. And I know you're a very busy dermatologist. You're an owner of the practice as well. But you also balance a very hectic family life, right?
Yeah. Yes, I do
Yeah.
have three children who
Uh-huh.
are aged 8, 10, and 12 now. So they're a bit
Okay.
older, a little bit more self
Yeah.
sufficient.
Yeah.
I have a very, very supportive husband who does probably, I would say, the lion's share of the mental load and physical
Hmm.
load at home with the kids.
Okay.
And so that allows me, yes, because I do work too much, shall we say, according to the family at least.
Yeah. Well, Cara and I know each other from the skincare world primarily. We've met on a few different advisory board calls and other fun things that we were able to do. And you really bring a really unique perspective, in my view, a unique perspective to the skincare industry, because you have such a strong surgical practice and you really think about how you utilize skincare for that type of patient in terms of truly prevention of of skin cancer, sun damage leading to skin cancer. But also you bring the strong aesthetic practice that you have into kind of all of your consulting. And so let's talk about, is that unique to Dr. McDonald, or do you feel like that is kind of how the Australian dermatologist really views things because of this heavy tumor burden that you guys deal with?
Yeah, look, I think it's definitely not unique to me, but it is something that in Australia we would be much more cognizant of and much more
Mm-hmm.
focused on. I think in Australia there are probably similar to elsewhere. We have some dermatologists that are really focused on medical dermatology, and unfortunately, I think that they don't integrate skincare enough into their practices because
Mm.
I feel like you need the pressure from the patients who are interested in skincare and want the best skin possible. When as dermatologists we're often dealing with something that's abnormal or broken or unhealthy skin, and we're just trying to get it back to normal. But
Mm-hmm.
then as dermatologists on the aesthetic side, we're crossing over into people who have normal skin who want better skin. They
Mm-hmm.
just want that next level. And they're a very different patient with a very different problem. And if you've only ever focused on getting the broken to normal and
Mm-hmm.
not really thought about how to take it to that next level, you miss out on a lot of the tools that we can use as aesthetic practitioners, particularly skincare, but also procedures, to help even get the abnormal to normal, I think,
Mm-hmm.
but
Mm-hmm.
certainly to get them to the best possible skin they can have. So, yes, in Australia, we certainly have a big group of dermatologists that are really medically focused and probably are not as focused on skincare or procedural work. We have a small group that are very much just surgical, doing, Mohs surgeons essentially.
Yeah.
And then we have a growing portion that have started to combine more aesthetic dermatology. I would certainly say in the last 10 years, pretty much every dermatologist who has completed their residency, integrates aesthetic, skincare, and medical
Okay.
into their normal dermatology practice. Whereas prior to that, it was less common.
And aesthetic wise, and I know you do a lot of laser work, are lasers very popular? Or do you deal more with the injectables?
Um, Me personally, I am more focused on injectables. I
Okay.
do more work in the KOL space with the injectables, and I think that kind of creative, artistic side of me loves that injectable part of dermatology. Our practice, we do a lot of lasers, and my co-director of my practice is more laser focused in just her aesthetic practice. So it's kind of a nice balance that she's got more laser expertise than me, and probably, you know, the other way around with injectables. But we certainly both do both, and we both have a lot of experience compared to probably an average dermatologist. So just on balance, more injectables for me. We have a lot of lasers in our practice, and we have, but in Australia, I would say that laser is not regulated at all, and so lasers can be sort of operated from, you know, anyone really with no qualifications through to aesthetic nurses, estheticians, dermal clinicians, dermatologists. So there are a lot of people who sort of seem to have a laser in their practice and somebody using it. I just had a patient the other day, and she said, "Oh yeah, I had this laser." She was offered, you know, a package, and I said, "What laser is it?" And she said, "Oh, it's the one that all the doctors have." And I was like, "Okay, that one," because she'd been told, you know, this is a package. We've got the best laser. It's the one that all the doctors have, you know. So there's just a big market out there, which is very confusing for patients. And as I'm always having to say to patients, because I might recommend a laser and the patient will say, "Oh, I've had that laser." And I'll say, "Yeah, but it's not the laser that does the job. It's the operator, really. It's the settings, it's the experience." So unfortunately, it is difficult for patients, I think.
Yeah, it's buyer beware, right? And we have that here in the States as well, where it's in so many different states, it's unregulated in terms of who can operate and drive the laser.
Yeah.
And so the outcomes vary widely between different places. And so it's absolutely is buyer beware. And I feel sorry for the consumer, honestly, because it's very difficult, especially as you try and compete on price, or they look at price as the major way of determining where they're going to go.
Exactly.
So as we kind of turn more towards skincare, Cara, you know, when you look at the skincare industry, especially as you speak with your patients and what you have in Australia, what's really exciting to you now? What are you focusing on and recommending quite a bit?
Look, I think, you know, the skincare world is certainly exciting because it's changing rapidly. We're seeing new developments all the time. I think what's again worrying is that, you know, there are a lot of confused people out there, and they are basing their skincare decisions off influencers, social media, and uneducated people who are being paid for advertising these products. And so what I'm seeing in my practice is actually a lot of people with problems from their skincare and a lot of confusion out there. And I think it is exciting that people are starting to realize that they need some expert advice in the area of skincare. And, you know, it is interesting that we always, as you know, go back to basics a lot of the time with skincare, and it can get awfully complicated. People can start to think that they need, you know, 18 different active ingredients in every skincare routine. And, you know, I'm a big one to simplify things, keep it simple, and try to get people into some consistency and with their key ingredients first before they start getting into those novel ingredients. But, you know, we are seeing really exciting.
So your key ingredients then are what, like tretinoin,
ABC, you know.
Yeah. Okay. Antioxidants.
Pretty much, you know, we've got our literally ABC, I think, is great for skincare, isn't it? We've got our, you know, retinoid family, which has so much evidence behind it. And of course, there are newer iterations. There are some retinol-like ingredients that are probably less irritating. And I'm sure we're going to see hopefully some science behind, you know, the alternatives to retinol, because at the moment there's a lot of ingredients that are starting to claim, you know, retinol-like action, but we don't have that good evidence behind them. The studies,
like bakuchiol
Yeah,
or Biden's
bakuchiol.
pilosa or something like that.
Exactly.
Okay.
And,
Yeah.
it would be great, wouldn't it, to have some of the science behind that,
Yeah.
like in terms of longevity and histopathology and, true, excuse me, true,
Collagen production. And
real science
yeah.
to prove that it's
Yeah.
equivalent or near equivalent. But, at the moment, it's still one of the gold standards to go back to the retinoid family. And then,
Okay.
the vitamin B group are so important, especially in Australia. We really promote niacinamide very strongly because there is evidence for that in terms of photoprotection, reducing our risk of skin cancer. So it's certainly a favorite ingredient. It's an old ingredient, but it's still good. And panthenol, another good
Yeah.
vitamin B,
Yeah.
and then vitamin C, my favorite.
Yeah.
We still want to have that in every routine if we can. We want to make sure we're packing those antioxidants in, and again, there are new forms of antioxidant that are really exciting, but we don't have enough evidence to give up vitamin C. That's for sure. It's still the best, still the gold standard.
Oh, I just have to tell you, I learned something. So the ABC is not something I haven't heard that in a long time. So just to make sure everyone understands, so vitamin A, right? Retinoids are vitamin A derivatives. Okay, so you've got tretinoin, which is all trans retinoic acid, then you've got others that, and then retinol, retinaldehyde, that are kind of precursors to tretinoin. So that's your vitamin A for the A. Vitamin B's, vitamin B3 is niacinamide, B5 is panthenol, for example. And so that's where she says ABC, and then C is vitamin C. I love that. I haven't heard that in a long time. I totally forgot about that. That's
Yeah,
great.
it's funny because it's obviously we use our ABC in our mole checks too,
Yeah.
but I think when you can come back to that really basic ABC plus your barrier and cleanser,
Yeah.
you're really, and obviously your sun protection there,
Yeah.
um,
Of course.
but if you've got people on A, B, and C, really
Yeah.
they're getting a very, very good skincare routine just back with those really old school basic ingredients that have come so far. And we now know that, we've got good delivery vehicles and lower irritation and so on from our current, options
Hmm.
available. But
Yeah.
if you've got confused people, it's a great place to start.
That's great. Okay. And so and it really just kind of sets the tone for, look, it's basic, and ABCs, we all understand that, but really this is, so as you said, justified by the science to use these ingredients, and completely agree. When you're looking at moisturizers, Cara, what are you
Can
what
I
are
just
you
say we can
looking
also go
for?
for D, which is DNA repair.
Ah, I
We can go
like
for
it.
E, which is
Okay.
vitamin E combined with,
Yeah.
good old C,
Yeah.
ferulic, which takes us to
Okay.
F, which is ferulic. So
Oh, we're going to go through to Z
you can
here.
keep going through that alphabet, but those first letters are pretty good.
Yeah, I like that. Yeah, and vitamin, the D for the DNA repair, we should not discount that, right? Because
No,
we have those really great products now that have a lot of research behind them to show that we can absolutely do that, especially in a sunny climate like in Australia, right?
yeah, absolutely, and that's where I like to sort of, as start with it's almost in order. Like, A is
Yeah,
probably the one with the most evidence. B is the next. C,
right. Yeah,
it's a great alphabet.
yeah. I love it. Okay, great. And then, okay, let's go back to your moisturizers. So now we're at M for moisturizers.
Yeah.
And so what are you looking for in terms of ingredients? What do you like to recommend?
Look, I think this is really a personal thing and varies a lot in skin type,
Okay.
by skin type. But
Yeah.
our ceramides are certainly,
Okay.
a favorite ingredient for people with dry, sun
Hmm.
damaged, eczema prone,
Hmm.
irritated skin, which is many, Australians.
Yeah.
Our other fatty acids, cholesterol.
Yeah.
I love just good old glycerin, which is a humectant.
Hmm.
Very good at holding moisture in the skin. Hyaluronic acid, it's got a lovely texture. A lot of people enjoy products with hyaluronic acid in it, but I think it's overhyped a bit in terms of what it actually does in topical application, and it really needs to be sealed in with a barrier to hold moisture in the skin. And shea butter and lots of again old school ingredients
Mm-hmm.
for barrier and moisture.
Mm-hmm.
But I do find that really comes down to patient preference and what their skin is like, because you can really find a good moisturizer or a good barrier for most people, but it does vary a little bit.
Yeah. And, just to circle back to hyaluronic acid, I think you're completely right. The issue with hyaluronic acid, in my view, is that most of the products up till now have been using single molecular weight HA, which, either high or low, and they do very different things. And some of the ultra low molecular weight HA is actually inflammatory in the skin. So you have to be careful with that. And so looking for products that have multi-weight HA is probably the best way to go, just because the low molecular weight tends to penetrate further. It acts as a humectant to bring water in. The higher molecular weight tends to sit on top of the skin, which hydrates the very top of the skin, but also acts as a moisturizer to seal in some of the water already there, the hydration there. So that's a great point. HA, you've got to be careful how it's used in a moisturizer, to your point.
Yeah.
Um,
And I think
okay. And
people get confused again because we inject HA
yeah.
all the time.
Yeah.
They assume that putting it on the top will give a similar or possible,
Right.
effect penetrating, but we know it doesn't penetrate through to the
Mm-hmm.
dermis. It's only really superficial epidermis. And as you said, if you go too low, it actually just becomes pro-inflammatory, which is not good for anyone, especially
Right.
for those with dry or irritated skin.
Yeah. And then because it's Australia and because we have an expert here, we should talk about sunscreen. And so,
Yes, my
look,
favorite topic.
yeah, I'm very jealous because the filters that you have available to you and your patients are so different from the ones that we have here in the States. But talk about, slip, slap, slop, of course, but, even further than that, how you integrate sunscreen, and sure, with everything that you do and all the different products that you have. It's amazing.
Yeah, look, it's actually an interesting point you make about the filters, because we've kind of got this mixed blessing with our sunscreen regulation. So the first thing in Australia is that sunscreen is regulated like a drug, and that's pretty
Uh,
unusual. So it has to
yeah.
be approved by the equivalent of our FDA to be named as a primary sunscreen, and our sunscreens have an approval number on them. They have to be manufactured or tested in only a number of approved testing facilities around the world. So when they say SPF 50, we know, that it is SPF 50. Whereas, I've seen a lot of literature around products that are labeled one thing, but actually not, they don't come up to that in testing, which is always
Right.
worrying, I suppose. But having said that, it takes a long time in Australia to get new products approved, and it costs the companies a lot. So even though the ones we have are very good, we sometimes are a little bit slow getting in new filters. And we also, for example, a brand like SkinCeuticals has multiple sunscreens, but we have one in Australia because it's just too expensive for them to try and get them all approved. And then most of them are manufactured in facilities that aren't approved by our TGA. So they just can't bring in multiple options for people. So we
Wow.
actually miss out on a lot of things as well. There's a new filter known as UV Mune, which has been developed by La Roche-Posay. You probably know,
Mm-hmm.
and it's got a longer. Uh, it's got a filter that covers a long more of the UVA wavelength.
A wider spectrum.
A wider
Yeah.
spectrum, thank you,
Yeah.
compared to our current, so long UVA,
Mm.
which we know again contributes to aging and our risk of skin cancer. And no other filters are really covering that part of the spectrum very well. But we still don't have it approved. Like, it is in approval, but we are waiting and waiting, and
Okay.
it's quite frustrating for us who are in the know, but also the companies,
Yeah.
that they treat it so seriously that they the kind of the regulatory bodies can make it very difficult. There needs to be enough science, enough studies to show that it's, this benefit and so on. And I think it's just a long, slow, expensive process for companies to bring sunscreens into Australia. So that's the downside of it. The upside is that, it is taken very seriously. Our sunscreens that we do have here are very high quality. And the message really is quite strong in Australia about photoprotection, which is great. It doesn't stop people from, thinking they're invincible. And we still see every day, some people that just don't, use sunscreen regularly, but more and more people are getting the message that sunscreen should be a year-round thing in Australia, because we just have such high sun exposure that it adds up all year, rather than it just being when you're going out to the beach or the park.
Yeah. I've got multiple family members that live in Sydney, and, the wives of my cousins are very careful with their sun exposure. Yeah. My cousins are not so much, despite me haranguing them and their wives haranguing them.
Anyone that's worried about wrinkles now understands that, we really need that sun protection. The people that don't really care about their wrinkles are still a little bit blasé, because I especially find that age group between about 15 and 25, they're pretty reckless. They still want to get a tan. Okay. And then, men as well, just, won't happen to me. I'll be right. Don't like creams.
That's a big problem. But in the States, we're getting this, a big issue now is called pre-aging, where these 15 to 25-year-olds are really focused on skincare. And so they'll go, many times I'll have a teenage patient come in with 5 to 10 different products worth hundreds of dollars.
Yep.
Because they are, influenced by social media or watching social media, which I'm not saying is all completely bad, right? To be aware of your skin, to be understanding of the effects of the sun and aging process, and the exposome, as we say, everything that can affect the aging process. It's probably not a bad thing when you're young.
No.
But it is becoming more and more popular, this idea of pre-aging. So we're seeing skincare companies now develop products just for that patient population.
Yeah, look, and we're the same here. Yeah. We've got these young people obsessed with skincare.
Okay.
Absolutely. But and look, I think they're putting sunscreen on their face and still sometimes going out and trying to get a tan on the body for the weekend, which, they'll learn. Over time that they don't want their body wrinkly either, I suppose.
So they're taking care of their face, but they let their body go. Okay, got it.
Yeah, they're less, in that age group, they're just less concerned about risk. They're less concerned about skin cancer. They're more concerned about how they look. So if it's a tan with a million skincare products on their face, that makes sense to them.
Okay, gotcha. As long, if they're putting the products on, at least it's helping them in some way.
Yeah.
Okay, got it. But as we know, we should say this just as a professional disclaimer: a tan is damage, so any tan signifies potential DNA damage and should be avoided, right?
Correct. Absolutely.
Okay. All right. Listen, Cara, I enjoyed this so much. I learned so much about you and about kind of being a dermatologist in Australia. Thank you so much for being with us.
Oh, my pleasure. Thank you again for having me.
Oh, this is great. So again, this is Skincare Confidential. I'm Dr. Ted Lane. Thank you for listening. Dr. Cara McDonald is our guest from Australia. Cara, what is your Instagram handle?
It is Dr. Cara _dermatologist. So DRCARA
_ dermatologist. Yeah, and I was just on today. I was on your Instagram, and you post some really educational stuff. I think it's great. So keep going.
I'm not great on the Instagram. I think there's a formula, and I don't seem to be able to follow it.
It's okay. Whatever you're doing, it seems to be working. So listen, everybody, thank you. If you like it, please give us a good 5-star rating, subscribe, and refer us to friends as well. We all appreciate your help in getting the Skincare Confidential word out so that we can get this great information to more and more people. Thank you very much.
Thanks for having me.